Thank you, sir, and thank you all the seniors. Thank you to the Absicon for inviting me for this session. So, I'm Dr. Neha Chaudhary. I'm a consultant at Narayana Super Specialty Hospital in the Department of Breast Oncosurgery. I will be starting with Chemoport Insertion. And Chemoport Insertion sounds very basic. It is a very basic procedure, but often we forget to offer our patients Chemoport. So, what exactly is Chemoport? Chemoport is a very basic central venous access, and central venous access, as we know, can be either short term or long term. Short term can last anywhere between 3 to 4 weeks, and long term could be from 6 months to 2 to 3 years. So 6 months would be something like a PICC line, and something long term would be a Chemoport or a port-a-cath as we call it. Just a second. Yeah. So this is how a Chemoport looks like. There will be a device which is placed under the skin, just like a pacemaker, and the catheter goes in one of the large veins, maybe in the subclavian or in the internal jugular, and the end lies just at the entry of the heart. And whenever we need the access, we prick the skin and we take the access. What is the advantage of Chemoport over any other central venous device? Because it is a closed system and the port lies under the skin, the chances of having any infection is less, any manipulation is less, and the patient can have their normal day-to-day activities. The need for multiple needle prick is less. There is no delay in chemotherapy because the patient is waiting to find a peripheral vein, and all the complications of chemotherapy in a peripheral vein like extravasation or thrombophlebitis is avoided. So what are the types of Chemoport? It could be either single lumen or double lumen, open end or Groshong, a power port where you can put with much more pressure or a regular Chemoport, and a pre-attached or attachable where this catheter can be either attached from the start or you can attach it later. Where all can you use a Chemoport? You can use it for all kind of things like infusion of medication, giving IV fluids, parenteral nutrition, blood products, and even withdrawing blood samples. So coming to the surgical procedure, what I'll be showing you today is I usually use a Groshong port. Groshong tip is a kind of tip, I'll be coming to it, and I use a 8 French MRI implantable barred access system. This is how the box looks. So coming to the Groshong tip, a Groshong tip is kind of a closed tip which stays closed at neutral pressure. It will open up at negative or positive pressure, but at neutral pressure it stays closed. So that helps in avoiding any kind of clot at the tip. These are the components of a Chemoport. So this is a catheter, this is a guide wire, this is the port with the locking device, tunneler, the dilator with the peel-off sheath, the insertion needle 18 gauge and the syringe, and these are access needles, and the Huber's needle is also provided in the kit. So at the start of the procedure, what you need to do is flush everything with heparinized saline. How do you make a heparinized saline? Usually heparin is available in a 5 ml bottle which has 5,000 units. So you take 1 ml of it, that is 1000 unit, and dilute it with 100 ml of normal saline. So that will make it 10 units per ml. So this is how you position your patient. Most Chemoports can be done under local anesthesia. However, if your patient is apprehensive, you can give some sedation or maybe a GA. So the position would be the patient is supine, neck extended and rotated to the opposite side, and give a slight Trendelenburg so as the veins are engorged. This is the draping. Now I will start the video. So I always use our ultrasound guidance to access the vein because that's the safest way. You can see the internal jugular vein clearly here, and using the insertion needle which has, the syringe has heparinized saline in it. It has been flushed, and you can see that I found the vein with the ultrasound guidance. So this is the internal jugular vein. The needle is entering. Yeah, and as soon as we enter the vein, we get a backflow of venous blood. We can see that. Once we get that, we can insert the guide wire. So at this point of time, you have to be very careful that the tip of your needle position doesn't change. So your hand should be very stable. Yeah, now we confirm the wire position on C-arm. And then we create an infraclavicular pocket, make a horizontal incision around 3 centimeter below the clavicle. Deepen the incision. I always go till the pectoralis muscle because it is better to fix the port to the muscle because it will not shift in position, and keep the skin flap a little bit thickened, otherwise your port might get exposed, the skin might thin out. So we make a pocket just big enough for the port to fit. It should not be too big or too small, just enough for the port to fit snugly. So you see that is the pocket. So now I'll be measuring the length of the catheter that has to be inside. So that is my insertion point till the second intercostal space. So in my case it was 13 centimeter. Now I make a small nick with the 11 blade at the neck incision, and then we enter the dilator with the peel-off sheath. Now this has to be very slow, sustained pressure, no forceful pressure. It should just go in without any force. So now the dilator is in. We remove the dilator. At this point there will be some backflow of blood. So you can maybe stop it and then put the catheter in to the length that we have measured earlier. That is 13 centimeter. Now we break open the tabs and peel it off. At this point also you have to be careful that the catheter doesn't come out, so someone should keep it in position. Again we check the position of the tip on the C-arm, we'll discuss that later. The next step is putting in the tunnel. So at this step there is one tip I can give, that is, you see the direction of my tunneler is not directly towards the neck incision, it is a bit lateral. The point of doing that is then my tract which will be formed at the neck, it will have a little bit wider angle. If I go directly to the neck incision, then it will form an acute angle and there will be kinking of catheter. So you have to go a bit outwards and then go in. So now this small instruction thing comes with the kit. I usually put it in because it helps me manipulate the position later on. And we have tunneled the catheter to the infraclavicular wound. Here you have to be careful that the catheter doesn't rotate. Now I am putting the lock in. And then we trim the catheter. Again there is one important point here. So at this position, at this point, what I do is that Trendelenburg position that I have given to the patient, I change that. I make the patient a little bit head up. The point of doing that is what happens is when your patient is lying in a Trendelenburg position, the neck wound and the infraclavicular wound, they tend to come closer. So that length is shortened. But when your patient is up and about, because of the gravity, it falls down. And then the position of the tip that you have decided, that changes and it comes out a little bit out. That is why at this point it is always best before you trim your catheter to make the patient sit up a little bit. So that way the position is perfect. I have trimmed the catheter and I am attaching the port. So one more point to note here is the lock has a black line. The black line should be away from the port, that is towards the vein. Now we check for backflow again. And flush the port. I'm using 3 OPDs to fix the port to the muscle. So what I do is I take all the stitches first and I take the knot in the end. That makes it easier. Now all the 4 knots are tied. Always fix at all the 4 points. You don't want the port flipping on later. Now you can see the skin over it is closing easily. There's no tension. And then we close the skin in 2 layers. I use 3O vicryl and 4O monocryl. And I always give subcutaneous stitches because I don't want to give a bad scar. This nick in the neck, you have to be very careful when you take that stitch. You can take one single stitch, but do not break the catheter going from there. Otherwise, it will be very catastrophic for the patient if there's leak of chemo over there. So you have to do this very slowly and carefully. So now this procedure is done. Now I'll show you how to access the port with the Huber's needle. Huber's needle is a non-poring needle which is specifically designed for chemoport access. And I've taken the needle, I've flushed it with heparinized saline and taken heparinized saline in the syringe. I've gone straight down after fixing the port and I'm getting a backflow and I'm flushing it. Now while flushing it also there is something which is known as positive pressure technique, where you keep flushing and while you are giving a positive pressure, you close the lock. So this way what happens, if there is any blood at the tip, it will move away and the chance of clotting at the tip is lesser. So that's the procedure done. Now, as I said about tip position, the recommended position is at the junction of S3C and right atrium. And it is very important to get this right, because if it is too out, then the chances of the catheter coming out is there. If it is too in, then your patients will have symptoms like palpitation. So on an X-ray, this is where your tip should lie, between the lower 2 lines. This is the X-ray of our patient. And regarding use and maintenance, inserting chemoport is only half the work done. The main and the most important part is to train your staff how to use and maintain it. Because if you don't do it, then you will get your chemoport failing every now and then, which is a very big hassle. Patients don't accept chemoport failing very easily because they have spent so much. So it is very important to use a syringe more than 10 cc, because a smaller syringe will have a greater pressure and may damage the catheter. always use only non-coring needles, not the regular coring needles that are available. The flushing is the most important part, because if the port is not flushed at the end of usage properly, there will be a block and the port will be useless to us. So there are different recommended port flushing techniques for regular port and Groshong port. However, I use heparinized saline for everything. So when the port is not used, every once in 4 weeks it should be flushed. When in use, after every infusion, using 10 ml of fluid, and after every blood withdrawal, using 20 ml of fluid should be used. So, and after that there should be 5 ml of heparinized saline. Coming to what all complications you can face, and these are all real complications which if you are doing high volume port insertion you will face. So you should know how to manage them also. Most commonly there will be some failure in the mechanical part. There will be either a block. Most common that I have faced is one-way functioning port, where you don't get a backflow but the forward flow is there. And this is usually due to a sleeve valve thrombus at the end. So there are techniques to kind of manage that. Apart from that, your catheter can get dislodged, catheter can fracture, there can be some catheter related venous thrombosis. This is one patient this is actually my patient which I had, and the whole catheter had come out and it was lying in the subcutaneous pocket. So this is one of my initial cases. Then there's something which is known as Twiddler's syndrome. So Twiddler's syndrome is when the patient has a habit of constantly playing with the chemoport, and they hold it and keep playing with it. So the sutures inside, they break, and then the port has a tendency to flip. So you have to tell and educate your patient, please don't do that. Apart from that, there can be infective complication, there can be bloodstream infection, catheter-related thrombophlebitis, port pocket and tunnel infection, and catheter-related septicemia. All of this happens if your the central venous access staff is not trained well and they are not using proper aseptic technique. So the conclusion is, port in current era where we are using so much of chemotherapy, it's a very useful device to have. It can be kept for as long as 3 to 5 years. Every institution should have a dressing and flushing protocol. Repeatedly train staff. I train my staff once every month, in fact, because these days there is so much of staff rotation. Well trained and preferably dedicated nursing staff should be there for proper handling of central venous catheters. And in case of any infection, pick it up early, give antibiotic early, try to avoid complication. Else you will have to remove it. Thank you.
Thank you, Neha, for nice presentation of port placement. Do you place always in the IJV or put in the supplement vein also?
Sir, I routinely place in IJV, but if need be, I can place in the supplement.
Okay. And what is the timing? You do it the primary surgery or do it afterwards?
Sir, it depends, both the ways. So I put chemoport even for non-breast cases. In fact, all chemoports in my institution are put by me. So all the cases.
So,
what is the rate of explantation? How many you have to remove?
Sir, I would say around 5 to 7%. So there are two steps. First, I would.
The question is, how will you judge that how much tube should be inserted inside catheter?
Yeah. So first is I measure the distance from the neck wound till the second intercostal space. That is my first checkpoint. Second, after insertion, I again check on CM because I use a attachable chemoport. So I can always pull in and out at the later stage. I don't have to trim and put. That is the advantage. And then if on the CM I can see it's 2 in or 2 out, I can manipulate accordingly.
We usually put it between the third and the fourth space. So about
Sir,
1 or 2 fingers below the sternal notch.
Okay.
Do you always put on the right side, or sometimes you have to put
So
on the
my-
left side also?
If I have the option of putting on either side, I put it on right side. But then in breast cases, if there's a right cancer and I know the patient is going to
Yeah.
receive radiation on the right, then I put on the left.
Some people would put the port on the left, I mean for a right-sided cancer, some people would put the port on the left side but the catheter in the right side. Would you do
That can be
that?
done. I don't do that unless I'm not finding the vein on the left and I'm failing multiple times.
Do you do
But
a-
that is an option, it can be done.
Do you routinely do a preoperative Doppler to look for the patency of the veins?
No.
Any other complications that you have come across, like detachment of the catheter from the port,
So I haven't
migration into the heart,
No, I haven't come across that. The most common complication is, as I said,
kink?
there is a block, there's a one-way functioning valve. So what I do is I try to flush a little, flush with Heplock and leave it for some time and then again try. Then we usually get a backflow. If we don't, after multiple attempts, our IR team helps us. Even if that doesn't work out, then you have to remove and change it.
And when, like how long after treatment completion do you take out the port?
After treatment completion, I usually wait for a year, ask them to keep flushing. Most cases, it is best to keep it for a year.
Mostly HER2 positive patients who would require Herceptin for a year.
So after completion of Herceptin also, I keep for a year. Unless the patient has problems coming for flushing every month and they ask for it.
Port removal could be linked to tumor subtype, triple negative HER2 positive.
Yes, I agree with sir.
Yeah, that's
So
what.
Everything nowadays is
Yes, so I assess that whether
Actually,
this patient is going to need more chemo.
ports are particularly more useful in patients who are HER2 positive because, I mean, you need access
So
and more number of
HER2 positive
times.
cases, bilateral breast cancers, patients who are not getting veins easily, all these definitely we need to put. But what I have increasingly started to believe that all patients should be offered chemoport. It is such a basic procedure. It makes patients' life so much easier. The hand that the thrombal phlebitis and the hand that they show is completely
Yeah.
avoided.
True.
And I think we are slowly moving in an era where all patients will eventually start getting chemoport.
The
for
cost is a
chemotherapy.
bit prohibitive. I mean, it's 20,000 for one. But, and I always feel that, there should be one extra sheath because once you tear it, you are done.
Yeah.
That set is wasted.
I have actually made that point to the chemoport company
Even I have
and
told
told
them.
them that you should give one extra
One spare.
fuse. You should have extra, independent
Yes.
few things which are. You cannot just extra dilator sheet or something you should be
Yes,
giving.
yes.
So I think they've started doing that. A few companies have started doing that now.
Let me know about
I think
those.
we are ready the operation. You can go to theatre. Switch
Thank
on to
you,
the
Abba.
theatre.
Heart, then you will require a cardiologist to do a interventional procedure, and I have had one
Yeah,
case. That happens
So
sometimes.
thankfully I haven't had
No,
that yet, but I'm sure your experience would be more.
When I
and
was
you can
in-
tell us what you did.
When I
Sir,
was in
what-
AIMS, I came across quite a few of such complications. We have published it also, like 4 or 5 kinds of complications. One was this catheter got detached from the port and it migrated into the heart. It had to be taken out by the intervention radiologist or, intervention cardiologist, whatever. Then in one case, the port, it was sutured to the pectoralis major. In spite of that, the port got twisted somehow.
Yeah, so that happens. In fact,
Then,
there are times when you can just manually
kinks
flip
are
it from
common.
outside. Yeah, and then it starts working again.
And once I got a recurrence
but
which had...
I've done that actually. I've done that.
Once I got a recurrence which had completely encased the catheter, a huge mass which had completely encased the catheter, and it presented like, a dubious. Yeah.
Thank you everyone.
No, thank you.